But at this point, I'd like to recognize the senator from Minnesota, Senator Smith, for a round of questions.
Well, thank you very much, Mr. Chair, and thank you, Ranking Member, for deferring. I really appreciate that. And thanks to all of you for your testimony. It's super interesting. There's so many questions I could ask. Dr. Inglesby, I'd like to start with you. Could you talk a bit? We know that AI was important in the way in which we developed the COVID-19 response, vaccine, how we responded to COVID-19, the historic pace of that, of testing and treatments and developed and vaccines as well. Could you talk about how, what are the lessons learned from that experience, and are there lessons learned as well for not only advancing treatments like the vaccine, but also preventing biosecurity risks, which we're talking about in this committee hearing?
Yeah, well, thanks so much for that question. I think what we have seen with vaccine development, new drug development, and AI tools is that AI can improve the speed and precision and efficiency of many processes involved in vaccine and drug development. They can start with the target and work backwards to decide what will attack that target on that pathogen most efficiently. They can predict toxicity. They can improve the efficiency of laboratory practices. AI tools are kind of across the board, can take on different components of the vaccine and drug development process and make them more powerful. But at the same time, those very processes could conceivably either inadvertently, accidentally, or deliberately be misused to identify things that could harm people on large scale, that could become products that, or biological constructs that could not be controlled. That's my greatest concern, is that we need to set up guardrails, at least to begin with, that are focused on preventing pandemic risks of things spreading in the environment, not being able to be controlled. And I think the companies themselves have said the same things. If you look at what they're saying in the public in the last year, many of the leading companies have said they are concerned about setting up guardrails around biological risks, and that is one of the things that they're explicitly talking about. I think the executive order begins to do that and has many steps moving in that direction. What I would do, though, is I think Congress should seriously consider going a bit further than the executive order, even now, because the role of government still is setting, in the executive order, setting standards, creating a testing process. But in terms of requirements for audits, a government audit of these companies, that's not yet there. And so I think that's the next important step.
You know, one of the things that I have been thinking about a lot is how do you overcome sort of the black box phenomenon of these AI models, and how you get accountability around bias, for example. I mean, there's lots of questions around accountability, but how do you think about it as you, from your perspective as a clinician, how do you think about that question of getting accountability in that sort of black box world where we're not exactly sure why or how the model comes up with its answer, let's say?
Yeah, I mean, I think that gets right to the heart of the bias questions that people have been talking about here. And there are many sources of bias. It can be data bias, it can be the model itself and how the model collected the data.
Right.
But one of the strongest things that people talk about in bias is getting rid of the black box, and the term interpretability is really the key concept around that. And I think that's just another way of saying that in healthcare-related AIs that will ultimately drive clinical care, we should be able to look under the hood and understand that process. And right now, with some tools we can, and some tools we can't.
Some tools we just have really.
And so, but that could be, for healthcare indications of AI, that could become a standard which the government insists upon. We have to be able to see how this, go reverse engineer it, understand how it came up with with the process and recommendations.
Right, right. It's, I mean, that question of how decisions are made and what is programmed into the model, let's call it, you know, gets to the core questions of accountability. Ms. Huberty, I was thinking about your story of the man who was, you know, kind of confronted with this prior authorization recommendation algorithm, which clearly was not being made in his, you know, decisions not being made in his best interests. And I mean, to be clear, I worry about humans in these big insurance companies also not correctly balancing the health risks of an individual with the marginal profit that they may incur by releasing somebody 7 days early or whatever it is. So I know I'm just out of time, Mr. Chair, but could you, like, how do you think about how we kind of get the right balance in these models?
Well, I think in these cases, there are humans involved in running the algorithms and adhering to those discharge dates, but even those humans involved have moral issues with those dates and how they're required to adhere to them within their own company. So I also just think the volume of it too, when you have so many of these denials running through that algorithm, the human oversight is only there when it's challenged. So only when there are appeals do you have that really detailed and careful human oversight where they're looking at the medical records. And so I guess my recommendation is to slow down, to get more of the humans involved, have more of the physicians, the treating physicians more involved as well, because the humans involved in those pieces never see the patients. They have no contact with them whatsoever.
Thank you very much. Thank you.
Great. Thank you very much, Senator Smith.